Hello, everybody. My name is Jenna Chapman. I'm a member of the Metriarch support staff. I want to let you all know upfront that this will be a recorded session. The recording and the slides will be sent out to all the registrants following the close of the conference. However, the recording feature will be turned off after the presentation has ended to allow for some privacy for our question and answer section today. Throughout the presentation, please feel free to reach out to me if you have any technical questions. But without further ado, I want to welcome Amani Wright and Victoria Patterson from Ariadne Labs.
Thank you so much. I'm going to go ahead and share my screen if that's okay.
Yes, let me make sure that you can. Okay, go ahead.
Okay, great. So can everyone see my screen? Awesome. So thank you all so much for being here. Amani and I are going to present today on an innovation that we are currently implementing and that we helped to design with our organization, Ariadne Labs, and it's called TeamBirth. TeamBirth is a process innovation. We'll get into the nitty-gritty of what that is and how we implement it. But for now, we'll just go ahead and introduce ourselves. So I'm Victoria Patterson. I'm a researcher at Ariadne Labs. I've been with Ariadne for about 1.5 years now. And I'm currently working on a project to implement TeamBirth at 2 hospitals in Tulsa. Amani, do you want to introduce yourself?
Yeah, my name's Amani Bright, and I'm a project coordinator at Ariadne Labs. And I've been here for about 4 months now, and it's been great. So I've been helping with the implementation of TeamBirth. So for today, our learning objectives are to discuss the strategies and structures to enable high-performing teams in childbirth to be person-centered, to recognize opportunities to incorporate the person's lived experiences in their childbirth care, and to identify how birthing facility context impacts implementation of structures for teamwork and communication. So for today, just a brief agenda. We'll give you some background on Ariadne and the team that we work on, the TeamBirth solution, the TeamBirth implementation, the TeamBirth pilot trial, our current TeamBirth work in Tulsa, and some summaries and takeaways. And here, just want to let you all know that we have nothing to disclose. So some background on what Ariadne Labs is. So it's a joint center for health systems innovation at Brigham and Women's Hospital and the Harvard School of Public Health. So what we do is create simple solutions to save lives and reduce suffering for people everywhere. Our organization was funded by Dr. Atul Gawande, and we're best known for the development of the WHO Safe Surgery Checklist. So this has been shown to reduce complications and mortality by over 30%. Our vision as an organization is for health systems to deliver the best possible care for patients everywhere and every time. Our mission is to save lives and to reduce suffering by creating scalable solutions to improve healthcare delivery at the most critical moments for people everywhere. So the way that we do this is by the widely recognized Ariadne arc. So what this is it was inspired by best practices from a range of industries and then adapted for public health specifically. So the Ariadne Lab arc represents a process of continual learning and collaboration. As our solutions advance through the 3 stages of the arc, so design, test, and spread, we collaborate with partners worldwide. We iterate as new knowledge is discovered and refine our approaches to do so. TeamBirth, the innovation we will discuss today, is currently between the test and spread phases. So the map you see displays some of the facilities across the goals which have assessed our tools. Our solutions are spreading to countries around the world and are currently reaching tens of millions of people. Our innovations and discoveries are adapted and implemented in a diverse setting so that we can improve the care for people everywhere. So the Delivery Decisions Initiative is a program at Ariadne Labs that designs, tests, and spreads innovations to promote quality, dignity, and equity during childbirth. At DDI, we envision a world where every person can start or grow their family with dignity by assessing childbirth care that is safe, supportive, and empowering. So birthing people and newborns can be harmed in two ways during childbirth: from too much care too soon or too little care too late. In some places, women do not receive even the most basic care, placing them in grave risk for complications and even death. In other places, women are receiving medically unnecessary interventions such as C-sections, a problem of overtreatment that is equally as dangerous for women's health. So this is what we focus on TeamBirth: reducing medically unnecessary interventions during childbirth to improve patient satisfaction and to reduce morbidity and mortality.
Sorry, I'm like clicking all over the place. Great, thank you, Amani, so much for that intro. So now I'm going to talk a little bit more about what TeamBirth actually is. So, and you're probably going to be so sick of TeamBirth by the end of this presentation, so I apologize, but TeamBirth is a care process innovation involving a series of team huddles between the patient and those caring for her, designed to empower each team member to contribute information, reliably structure communication with each patient, and help the team arrive at shared plans together. So for patients, TeamBirth invites them into the conversations that are already occurring amongst members of the clinical team, and it provides a structure that is easy to understand and participate in. And for clinicians, TeamBirth encourages all conversations to be had with the patient to promote effective full care team communication and alignment across all members of the care team. And so by providing a structure for effective communication, teamwork, and shared decision-making throughout labor and delivery, we hope to improve dignity and safety during the childbirth period. And to achieve these aims, we provide these three things: tools, implementation support, and measurement strategies. So the tools, which we'll dive into next, prompt and support TeamBirth behaviors in the moment of care. Our implementation support is to provide strategies for aligning processes to support the TeamBirth behaviors. And our measurement strategy helps to provide feedback throughout the implementation process to adapt, coach, and reinforce TeamBirth behaviors with an eye on sustainability. So to illustrate how the TeamBirth solution gets us to these ultimate goals on the right side of this causal pathway of improving safety and improving dignity, we're going to walk through this causal pathway throughout the presentation. And we start at the left with our two core design principles: simplicity and teamwork, which we believe are essential to delivering high quality care consistently and reliably for every patient, everywhere, every time. And the reason that simplicity and teamwork are so important is because for every person in labor, a clinical care team is established somewhat ad hoc and may be comprised of people that have never worked together. But at the same time, this team has to come together and be high performing during childbirth. And it turns out that when things go wrong in clinical care, the most common root causes are failures of communication. So by improving teamwork and effective communication among all members of the care team, we believe that we may be able to prevent adverse events from occurring in labor and delivery. So back to these design principles. So the way that TeamBirth enables teamwork is we focus on creating psychological safety. So we accomplish this by ensuring everyone in the room including and especially the person giving birth, feels permission and opportunity to speak and be heard, and that we are giving the birthing person the information that they need to make a shared decision with their clinical team. So to promote teamwork, we promote psychological safety and shared decision-making. And we focus on really involving the patient in their care rather than just telling them what's going to happen or telling them what the clinical team believes is best for them. TeamBirth also promotes simplicity by putting methods and tools in place to allow for information to be easily and reliably communicated across the full care team, including with the birthing person. So by structuring communication, we believe TeamBirth is the simple way of improving care while making it easier, not harder, for clinicians to do their jobs. So we separate the TeamBirth tools and behaviors into two designations: core and flexible components of the intervention. And core components are those which are critical to the success of the intervention, so they must be performed to ensure that you are really doing TeamBirth. And as you can see from this slightly blurry visual, our two core components for TeamBirth is this shared labor and delivery planning board, and then our structured team huddles. So TeamBirth huddles. So the TeamBirth care process innovation, it's based around these regular team huddles that involve the full care team, again, including the person in labor and their support person, and give all team members the opportunity to speak and participate in shared decision-making. So one way of thinking about TeamBirth, one of our implementers at our pilot site said this once, and I thought it was so great, is you're just taking everything that normally happens in the hallway or at the nurse's station, and you're bringing it to the bedside so that the patient is involved. So that's sort of the who, making sure that the full direct care team is involved. As for the what, we will get into that with the shared planning board, but the shared planning board prompts clinicians and the clinical care team to have a certain conversations with the birthing person, including discussing their preferences, their birth plan, anything that they're hoping to get out of their labor and delivery experience. Huddles typically occur at admission, decision points, or changes in the plan of care, but they should also occur at the request of any team member. And again, the reason that we do this is to give all team members the opportunity to participate in shared decision making. So as I mentioned, these huddles are supplemented by our shared planning board, and it really is as simple as it looks. Our shared planning board replaces the dry erase board that's already in many labor and delivery rooms, but it's bigger. So we recommend that it be at least 2 feet by 3 feet in dimension. And the reason for this is so that the birthing person can see and read all of the information on the board from their bed. And like I said earlier, this board serves to structure the conversations that take place during the huddles. So we denote space for the team. This is where all the team members are listed by name: the nurse, the patient, their support person, the doctor, anybody that might be coming in and out of the room. And the purpose of that is just to sort of bring everybody into the team, let everybody know that they're part of the team and they have permission to speak and be part of this experience. We have a section for preferences. So this is where the birthing person's preferences go. It can be updated at any time, but it might be something like wants to avoid a cesarean delivery if possible, or no epidural, that sort of thing. On the right side, we have the care plan, and we denote, or we separate it by mom, baby, and labor progress. And so this is just to reinforce that there are different plans for mom and baby at different times throughout labor. So for baby, it might be continuous monitoring. For mom, it might be get up and walk around, or have a drink if that's allowed. And then finally, we have this section called next assessment. And this is always our patient's favorite section, because this is where the doctor or the nurse or some member of the clinical team denotes when someone will be coming to check on the patient next, so that they're not just hanging and wondering when they'll be checked on. And so again, by having all of this up here, having all the names on the board, we're trying to create a safe space for shared decision-making, but we're also trying to make sure that there's accountability in place so that the birthing person's preferences are really being honored. Once something's written up, it's hard to change the plan without confirming any changes with the birthing person and their support person. So now I'm going to briefly get into our flexible components. So the board and the huddles are non-negotiable, but there are other things that can be tacked on or sort of changed to make implementation of TeamBirth customized for different facility contexts. So one add-on option for TeamBirth is to add on our discussion and support guides. So we created these to assist the clinical team to make, not to make better decisions, but to make more informed decisions that are the same for every patient. We have an admission discussion guide. So this is for triage nurses to use to decide if it's really worth it for the patient to be admitted, or maybe if the patient would be more comfortable going home and returning later. We have a labor support guide. This is a patient-facing guide that gives the birthing person options, comfort measures, and other things to try to improve their experience of labor and delivery. And then on the right here, we have the assisted delivery discussion guide. And this guide is to assist in team discussions about assisted vaginal delivery or cesarean delivery to make sure that the clinical team is running through all of the details with the birthing person before arriving at a shared decision. These are some examples of adaptations we've seen in our pilot sites. So for example, the huddles have been adapted in various ways. The format, we prefer in-person huddles, but we found huddles over the phone to be very effective as well. If the physician isn't in the hospital or can't get there immediately, patients really appreciate it to just have the physician on speakerphone in the room so that they can hear their doctor. Huddles can also be adapted based on timing. So we said any major changes in the care plan or any major decision points, there needs to be a huddle, but also at any request of a team member. And that might mean something like having a little tuck-in huddle before nighttime to just get the patient up to speed on what the overnight plans are. And then again, I apologize, oops, this got cut off, but the care team can be amended depending on who's involved. You might have an anesthesiologist, you might have a neonatologist, and anybody that's coming in and out of the room should be included. Other site adaptations are the board. So you can take our simple board on the left and make it your own. Over Lake Medical Center, again, one of our pilot sites in Bellevue, Washington, put these beautiful mountains in the background, and they kept all of the sections that are most important, but they added in some prompts under my care team to really make sure everybody's listed. Okay, so now I'm going to describe just briefly a little bit of what TeamBirth implementation looks like. And we're going to keep following this causal pathway. So this part is, we've introduced the tools, and now we're getting into the implementation, coaching, and feedback. So when we talk about implementing TeamBirth, we follow this implementation pathway, and it's structured as a circle because we understand that change is never linear, and you may need to sort of jump back and forth between phases of the implementation pathway. But we separate ours into 4 phases. The first is prepare. And this is when you're really building your hospital-based implementation team, building support for TeamBirth in your hospital on your unit, and making sure you have a set implementation strategy. Our next section is engaging coach. So this is when we're training champions, testing and adapting TeamBirth, and training all of the staff and providers. And then we have the implement section. So this is when we're actually launching TeamBirth in the hospital, collecting data and feedback from patients and clinicians, and really beginning to build for sustainability. And then finally, we have sustain. So this is when you're building continuing and ongoing measurement strategies and integrating them into your TeamBirth implementation plan and making sure that systems are in place so that your hospital can keep going with TeamBirth. Okay, so now Amani is going to talk a little bit about our TeamBirth pilot trial.
So now that you all have a bit of background information on what TeamBirth is, we're going to transition to discussing how TeamBirth has been implemented and what we found that TeamBirth can accomplish, including improving teamwork and communication during childbirth. So in our pilot trial, we tested TeamBirth's ability to improve communication and teamwork among 4 hospitals on both coasts of the US and in Tulsa. So we saw that many interventions are proven to be clinically effective, but few studies assess whether an intervention is feasible to implement. So in the context of TeamBirth, are the huddles happening and is the planning board being used? Second, is it being implemented with high fidelity to the aims and behaviors of the program, including the frequency of huddles and planning board use? And lastly, is it acceptable to both clinicians and patients? So we assess these aims through a mixed method approach, including interviews, surveys, observations of huddles, and clinical outcomes data. Feasibility was assessed as the patient-reported ability of clinical teams to implement TeamBirth with high fidelity. Patient accessibility was measured as the patient-reported experience of care, including their role in care and the perceptions of communication and teamwork with their clinical team. And this was assessed through patient surveys with both closed and open-ended survey responses. Clinician acceptability was measured as the clinician reported perception of the value of TeamBirth and the impact that TeamBirth had on care and decision-making. So with this, we conducted in-depth interviews, clinician surveys, and focused group discussions that collected these measures. We also measured the safety with maternal and neonatal outcomes as balancing measures. So moving to patient acceptability, these results come from our patient surveys. And overall, we found that patients felt that they had the role they wanted in making decisions about their labor. The provider also spoke to them in a way that they were able to understand their labor and care. And the patients felt that by sharing their preferences, it made a difference in the care that they received. So what's interesting here is that the data shows that the more huddles a patient participated in, the more positive their birth experiences were across a different number of dimensions, which reaffirms our hypothesis that patient engagement is key to shaping their birthing experience. So for example, if we looked at the last set of data, did you feel that sharing your preferences made a difference in the care you received? We observed almost a 20% point difference in people reporting that sharing their preferences definitely made a difference in the care that they received between patients who reported no huddles and those who reported several huddles during their childbirth. And here are some quotes from interviews and focus group discussions with patients and clinicians that describe the patient's experience with TeamBirth. So for the first one, my L&D team was awesome. I love how they kept me in the loop and made me feel confident in my birth plan. They continuously updated me on the timeline and what was next, and that made me super comfortable. So looking at clinician acceptability. So these results come from the clinician surveys. So among the clinicians surveyed, after 8 months of implementation, 90% of nurses, midwives, and obstetricians reported they would definitely or probably recommend TeamBirth for the use in other labor and delivery units. So these open-ended survey responses revealed that clinicians' main reasons for recommending TeamBirth included involving and empowering the patient and their family in care, improving team communication, and creating transparency and accountability for all team members. And just another snapshot of the data, 94% of clinicians reported that the project definitely or somewhat improves the care for patients. And 88% reported that the project definitely or somewhat helps clarify when a C-section delivery should be performed in a non-urgent situation. And here are some quotes from clinicians that represent their view on the TeamBirth implementation at the hospital. Communication is key to keeping our patients safe and our babies safe. And TeamBirth certainly correlates to better patient care, and it correlates to a better environment to work in for everybody. And finally, we observed no substantial changes in maternal and newborn safety measures at any of our pilot hospital. So this indicates that TeamBirth is safe to implement. At our highest performing hospital, we observe a promising trend in low-risk C-section delivery rates following implementation, with the hospital achieving and sustaining its lowest NTSV rates since they started collecting the measure. So now looking at the outcome portion of the causal pathway, the ultimate goal of TeamBirth is to improve patient safety and dignity during childbirth. So we think of improving safety as reducing the rate of non-medically indicated C-section deliveries. And we think of improving dignity as increasing the number of birthing persons who report a positive childbirth experience and report being able to participate in their care. So moving on to our current project implementation in Tulsa. We're working at Hillcrest and the OSU Medical Center, being funded by the George Kaiser Family Foundation. So here's just a snapshot of the disparities that we see among Black and Indigenous women compared to white women in maternal mortality, and just the rankings of maternal mortality outcomes across the US compared to Oklahoma. So our TeamBirth Tulsa project aims are to provide a structure for effective communication, teamwork, and shared decision-making to improve the experience of childbirth for all birthing persons at Hillcrest and OSU. The second aim is to identify the contextual enablers and barriers to successfully implement TeamBirth among a diverse population. And third, to test TeamBirth as a solution for racial inequities in childbirth experiences.
Great, thanks, Moni. I'm just going to jump in with our data collection methods for our TeamBirth Tulsa project. So really similar to the pilot trial, we are doing a mixed methods approach. We're doing surveys, interviews, focus group discussions. But what's slightly different about this project versus our pilot trial is that this time we're actually using validated surveys for both our clinicians and our patients, that we'll be able to compare the responses to other studies that have been done. And so we wanted to provide a snapshot of some of the surveys that we're using because we're just really excited about them. So the first is the Mother's Autonomy and Decision-Making Scale, or the MADAM scale. So the MADAM reflects person-driven priorities and reliably assesses interactions with maternity providers related to a person's ability to lead decision-making over the course of maternity care. And we chose this survey to include for our patients because, as you can tell, TeamBirth is so centered on shared decision-making and being able to promote shared decision-making. This felt like a great way to get into the details of whether patients felt like they actually did have autonomy in decision-making. It's really short, so you can see all the items that we're including here. And basically the patient will be asked a pre-screener question that says, who was your primary provider that cared for you during childbirth? And they select obstetrician, family medicine provider, or I believe midwife is the third option. And then it auto-populates into those blanks there. Something we decided to do as well is ask all of these questions with the provider type and then ask them a second time and fill in the blank with clinical team. Because TeamBirth is such a teamwork oriented solution, we want to delineate any differences in responses between their experiences with one specific provider type and then the clinical team overall, because the goal of TeamBirth is really to improve teamwork among the full team overall. And then the second validated scale we're using for our patients is called the MORI. It's the Mothers on Respect Index. And so this measures the birthing person's experiences of respect and self-determination when interacting with their maternity care providers. There are 2 other sets of questions, part of this survey, that involve prenatal care and pregnancy experiences. So we are just focusing on this set of 4 questions because it focuses specifically on labor and delivery. And we want to get at whether our patients feel like they were treated poorly by their clinician because of their race, ethnicity, cultural background or language, sexual orientation or gender identity, health insurance, or difference in opinion with their caregivers about the right care for themselves or their baby. For our clinicians, we're using the Safety Attitudes Questionnaire. It's one of the most widely used instruments to assess safety culture among healthcare providers. And it assesses maternal healthcare workers' attitudes through multiple domains. We're only focusing on 2 of those names, teamwork and job satisfaction. And again, there's only a few items here, so they're all listed here. But teamwork climate is just really focused on the unit culture surrounding teamwork. And job satisfaction is positivity about the work experience. Okay, great. So we're going to just dive into a bit of a summary now. So just to recap, TeamBirth is a care process innovation. And what we mean by this is we are trying to embed TeamBirth into the processes that are already taking place on labor and delivery. So we're trying to make it easier for clinicians to do their jobs, not harder, and not bog them down with any sort of QI intervention that they might be worried won't be effective. And so the way that we do that is just by swapping out their current dry erase board with one that's slightly bigger, structuring the conversation that takes place in huddles to make sure that patients are invited into the conversation and feel like their voices can be heard, and then documenting those conversations on that dry erase board so that everyone in the clinical care team can reference it throughout the course of childbirth. So for future work, we are hoping to generate more data and evidence. We have yet to do a really large scale trial of TeamBirth to prove that any clinical outcomes are statistically significant. So as Amani described, we did see decreases in the NTSB cesarean delivery rate at our pilot hospitals, but these were not statistically significant. Our study was underpowered to prove that because we didn't enroll enough hospitals. So that's a big body of work that we're really hoping to invest in the near term. We want to continue to adapt our solution to make sure that it really works for all facilities in different contexts. Higher resource, lower resource, academic, community hospitals, all of them. We want to build scaling infrastructure. Our goal is for TeamBirth to be the standard of care for every patient in every labor and delivery room. And the way that we implement TeamBirth takes a lot of our time on our team. We do a really hands-on implementation strategy. So we want to figure out a way to scale it more effectively. And then just continuing to cultivate partners and networks. We want to improve upon our community engagement. We've been working a lot on that with our GKFF Tulsa work, but we want to continue to build more of those connections. So I think that's just about it for our presentation. We would love to answer any questions that you might have. I'll probably just stop sharing my screen for now. And just thank you all so much for being here and tuning in. We really appreciate it.